I've, I've come with the remaining part of my last lecture on heat stroke and heat stroke. Now, cooling measures, there are some cooling measures. The biggest predictor of outcome is the degree and duration of hyperthermia. External cooling techniques are easier to implement and are effective, well tolerated, and include the following: conductive cooling, direct application of sources such as hypothermic blanket, ice bath, and ice packs to neck, axilla, and groins. Ice packs are effective but poorly tolerated by the awake patient. Avoid vasoconstriction and shivering, as vasoconstriction impedes the heat loss and shivering creates heat. Convective techniques include removal of clothing and use of fans and air conditioners. Evaporative cooling can be accelerated by removing clothing and using a fan in conjunction with misting the skin with tepid water or applying a single layer wet sheet to bare skin. Shivering may be suppressed with IV benzodiazepines such as diazepam 590 or lorazepam, that is 1 to 2 milligram. Immersing the patient in ice water is the most effective method of rapid cooling, but complicates the monitoring and access to the patient. Internal cooling techniques such as ice water, gastric or rectal lavage, thoracic lavage, and extracorporeal blood cooling are effective, but they are difficult to manage and are associated with complications. Cold peritoneal lavage results in rapid cooling but is an invasive technique contraindicated in pregnant patients or those with previous abdominal surgery. Cold O2 means cold oxygen and cold IV fluids are useful adjuncts. Step number 5, specific management. Malignant hyperthermia and neuroleptic malignant syndrome. Dantrolene, a non-specific skeletal muscle relaxant, is the mainstay of treatment. It attacks by blocking the release of calcium from the sarcoplasmic reticulum, thereby decreasing the myoplasmic concentration of free calcium and diminishes the myocyte hypermetabolism that causes the symptoms. It is the most effective if given early in the illness, when maximal calcium can be retained within the sarcoplasmic reticulum. There is associated risk of hepatotoxicity with dantrolene, so it should be avoided if liver function tests are abnormal. Step 6, that is manage complications. Number 1 is rhabdomyolysis. Expand the intravascular volume with normal saline and administer mannitol and soda bicarb. Alkalization of urine prevents the precipitation of myoglobin in the renal tubules. The goal is to prevent the myoglobin-induced renal injury by promoting the renal blood flow, diuresis, and urinary alkalinization. Monitor serum electrolytes to prevent life-threatening arrhythmias. Now I am going to a flow diagram. That is, get the victim out of the sun to a cool place, preferably one that is air conditioned. Discontinue the presumed causative agent and neuroleptic anesthesia and halogen should not be given. Give IV diazepam 5 mg IV. If the patient is having seizures, next you assess the breathing and pulse. And you from here you will be divided into two parts. One is pulse and breathing present. Next is pulse or breathing absent. Oxygen inhalation in those who are present, pulse and breathing. Oxygen inhalation, cold IV fluids, measure the core temperature. So, and in the other group, pulse or breathing absent, so you take recourse to ACLS CPR protocol. Now, in the first case, neuroleptic malignant syndrome. Discontinue the neuroleptic like bromocriptine 2.5 milligram per hour every 6 to 8 hours, titrated up to a maximum dose of 40 milligram per day. To be continued for the 10 days after this is controlled, and then taper it. Or you can give amantadine 100 mg per day per hour and is titrated to a maximum dose of 200 mg every 12 hours. Or dantrolene 1 to 3 milligram per kilogram IV initially, that is, total will be 10 mg per kg per day. Now, in heat stroke, get the victim out of the hot area, loosen the garments, give cold IV saline, give high flow humidified oxygen, do external cooling and avoid the vasoconstriction. Do internal cooling, treat the complications. Now another group is malignant hyperthermia. Here you remove the trigger drugs, turn off the vaporizer, use high fresh gas flow oxygen, use new non-rebreathing circuit, hyperventilate, maintain the anesthesia with IV agents, and dantrolene 2 mg per kg IV initially and repeated every 3 minutes until the symptoms abate. The maximum dose is 10 mg per kg, followed by 4 to 8 mg per kg per day. Per oral in 4 divided doses into 3 days. Use the active body cooling but avoid vasoconstriction. Give cold IV fluids. Cold peritoneal lavage and extracorporeal heat exchangers. Now, what will be the ICU management? Continue monitoring and symptomatic treatment. Assess for renal failure and constipation, renal failure and compartment syndrome. Give the further dantrolene as necessary. Consider other diagnosis like sepsis, pheochromocytoma. This all will lead to treatment of the complications. Hypoxemia and acidosis. 100% oxygen, hyperventilate, sodium bicarb. Hyperkalemia, sodium bicarbonate, glucose and insulin, calcium chloride. Myoglobinemia, fourth alkaline diuresis. Keep urine output more than 3 ml per kg per hour. Urine pH more than 7. Disseminated intravascular coagulation. Fresh frozen plasma, bioprecipitate, platelets, and cardiac arrhythmias. You use the procainamide, magnesium and amiodarone, that is quaterone. Avoid calcium channel blockers, interaction with the dantrolene. Refer the patient and family to malignant hyperthermia testing center for contraction or RNA testing. Now the next point is hypotension. To sustain organ perfusion, maintain the mean arterial pressure of more than 65 mm or mercury. By fluid administration, consider the vasopressors and monitor the central venous pressure. Seizures should be controlled by IV benzodiazepines and barbiturates. Multi-organ failure. Give supportive therapy until the organ function returns. Step 7, that is the prevention. Hyperthermia caused by physical exertion or hot environment can be prevented by taking frequent rest breaks and staying hydrated. Genetic testing for known mutations of the skeletal muscle ryanodine receptor in conjunction with in vitro muscle contracture test can be used to evaluate the individual susceptibility in the patients from family with a history of malignant hyperthermia. This point is very, very important. Thank you. I will come up with interesting topics day by day. Keep listening and subscribe necessarily.